All right, we're going to get started. Before we roll, I just want to take a moment to acknowledge the tragedy this week involving the Deere family, and specifically Barbara and Caleb Deere. They both were extremely close to me, as was Dennis Deere, and I know many of you share the same experience with the Deere family. Barb, quite simply, each and every day, lived Galatians as she loved and she served the community. And she grew up in North Lawndale. She and Dennis started dating at high school, Westinghouse. I always said to Dennis he had outkicked his coverage, which he had. She was just an amazing person who I worked closely with when we lost Dennis June of 24, relative to Juneteenth, Illinois. I grew very close to the twins as well, Kanan and Caleb. They call me Unc, I call him nephew. Caleb reached out to me on the 28th of March, the day we had a celebration of life for my niece, just to check on me. He was a wonderful person who was fighting issues that many of us are fighting. So please keep the family in your prayers. Thank you for everything that you've done. To the Staines family, thank you for how you've stepped up. We appreciate you. And let's just continue to embrace Kanan and Trinity and the rest of the Deere family. So a moment of silence. Thank you.
Mr. Chairman,
Please, Bob.
While not a member of the committee, so I'm here in attendance, I was just, we did this earlier at the previous meeting, so I'm going to keep this one very tight to something you mentioned. There's nothing that used to bring a bigger smile to my face than seeing pictures of Dennis and Barb from what I believe was high school, or when they were in college. They went to college together, I believe, as well. And the Dennis was very dated in all those pictures based on the sweater. The fade was incredible, and the multicolored sweater was straight out of the 90s. In fact, I long ago burned a similar sweater. Both very incredible people, as you know. Dennis is a dear friend of mine as well, and you know the incredible work that the Deere family has brought to the county and to the hospital and to our community. I look forward to continuing it on in their name.
Thank you. Thank you. Okay, roll call.
Director Harrington?
Present.
Director Masuda Barnett? Present. Director Staines? Present. Chair Lowry?
Present.
And for the record, briefly, Director Ryder. You have a quorum.
Thank you. Any additions to the agenda?
No, sir.
Any public speakers?
No, sir.
Director Harrington now moves to accept the minutes of the Managed Care Committee meeting held on February 6, 2026, seconded by Director Staines. All those in favor say aye.
Aye.
All opposed? In the opinion of the chair, the ayes have it. We will now hear a report from Health Plan Services presented by Aaron Galiner, Chief Administrative Officer of Health Plan Services. Aaron, thank you.
Thank you, Chair. Good morning, directors. We'll start with some of our typical metrics today, starting with current membership is at 381,000. I'll talk a little bit about the trend over time here, and then we have about 26,000 of those patients are impaneled with ACHNs. The next slide shows some demographic information, which is something that the committee's requested in the past. So the chart's a little small to see here, but you can see the breakdown on this slide. On the next slide, This shows our redetermination and choice rates. This is really two of the key underlying drivers of our overall membership. So redetermination continues to be in the 86, 87, 88% range over time, which has been fairly consistent. And then on the choice rate, which is a key measure that we're looking at in terms of how we look at the ultimate outcome of all of our different member experience efforts, we continue to see that increasing over time as well. And so I think both of those underlying drivers are in a good state, but there's a broader concern just around overall Medicaid enrollment right now, which we'll talk about when we look at some of the trends on the next couple of slides. This shows our market share data. So we are at 35% total market share through January of 2026. This is the high watermark for us as a health plan. 35% is the highest we've ever been. We've reached this point once before, right before the termination of the HPIA members from coverage, and so it's nice to see that we've built back up to that point. And again, this day is through January, which is what's most recent data published from the state. This shows that trend that I was mentioning before. So on the right-hand side is the total Medicaid enrollment in Cook County, which you can see continues to decrease. So that's overall what the market looks like. We're following a very similar trend on the blue line on the left, although our trend has been slightly lower in terms of the decreases than what the overall market has seen. So the net effect of that is our market share has been increasing, as we've been retaining members at a slightly better rate than the overall market is seeing in terms of decline.
Do you think that's because of all the work you're doing on redetermination?
Yeah, I think that's a combination of doing better in terms of our overall redetermination work. So we've seen, it's been a while since states published data on this, but we were historically at the top of the NCOs in terms of retaining people into coverage. And then as we've also seen, that choice rate has continued to increase for us. You know, a couple of years ago, that was around 20%, and it's now almost at 33%. So that's helped us sort of sustain, you know, even though the market's continuing to shrink. This shows our budget versus our membership budget and actuals versus projected. The blue is actuals here over budget. We're continuing to expect we'll see membership declines as, you know, we see in that overall market trend, but we are currently ahead of budget and expect that'll likely continue throughout the rest of this year. And don't expect any real drastic changes in terms of the current trend. We expect sort of those slow month-over-month decreases to continue as we head towards 2027, when we know a lot more of the bigger coverage changes are coming. And this shows our overall claims payment timeliness. As I've mentioned in past meetings, especially at the end of the year, that's a particularly challenging time for us as we roll over budgets, et cetera. I'm happy to report we've driven down a lot of this aging and are now pretty much operating within the required 30-day timelines again. And that's something that we've had a lot of sustained focus on over the past several months. All right, switching to some of the activities and first quarter wins overall for the health plan. So we are in the middle of our current CAP state surveys, which is the member experience surveys that are also part of our overall quality scores. We are in the final few weeks here of fielding those CAP surveys. Initial data looks really strong on those, but we still have a couple weeks to go, so I don't want to jinx that. But we are also we did our HSAG audits, which is the state's audits of how we comply with state contractual requirements. We had 100% scores throughout those audits, which included a multiple day on-site work as part of that audit. And then we've continued to see through our pulse surveys consistently high member ratings of us, what we call the Net Promoter Score, in terms of how members are reporting their overall experience with us. In terms of workforce, we recently held another all-staff town hall. We've also received back our employee engagement surveys and saw an increase in our employee engagement scores, which was nice to see. And has been a focus area for us, and then we've continued to have opportunities internally for individuals to take promotions within our team. On transition growth, we've had consistently high choice rates, as I mentioned. Can you go back?
I misinterpreted that pause.
Sorry. We've also continued to build on our HEDIS supplemental data. This is a core strategy for us to continue to build increases in our HEDIS scores. We've had some additional providers come online with that, which has been impactful for us. We're continuing our redetermination works, including over 30 redetermination events throughout the first quarter. And we've also been doing a number of what we call strategic partnership reviews with some of our core provider partners to continue to evaluate their performance on HEDIS, how we can better partner with them, and continue to drive on opportunity areas that we can collaborate on. Then, of course, last but not least, we've been spending a lot of our focused effort on fiscal resilience and finance initiatives. We've executed on over $32 million in savings opportunities in this first quarter and have an additional $40 to $50 million of savings initiatives lined up that we are trying to execute on over the second quarter of this year as we continue to look to right-size our financials. Okay. On the topic of financials, I wanted to provide some context. I know this is not the Finance Committee, but I wanted to give sort of a step back and a broad overview of what's happening nationally and kind of industry-wide, and then talk a little bit about some of the specific things we're seeing within the County Care Plan, and then talk a little bit about some of the actions we're taking to address that. So this provides a summary of medical loss ratios, what's called MLRs, which is the ratio of revenue to medical expenses that health plans have. And this looks at a broad swath of sort of the national for-profit health plans. And as you can see, pretty much across the board, all health plans right now are seeing significant increases in their medical costs. And that's really driven by kind of two overarching things. The first is as membership has continued to decline in Medicaid, the population that's been left in Medicaid nationally is a sicker, higher acuity population. The way the rate setting cycle works with states, it's based on data from basically 2 years ago. So while the membership and the population has shifted, the rate funding cycle of Medicaid hasn't fully caught up to that change in acuity yet. And so nationally, all health plans are sort of seeing this impact. And then specifically for County Care, I think, as I'll show here on the next slide, we're starting to see impacts in terms of our own MLR that's driven by both that kind of funding cycle, but also we think some changes in behavior in terms of members based on what's happening with federal policy changes and coverage. So you can see on this slide, this is our overview of our own medical loss ratio from 23 through 2025. For some context, our sort of break-even point as a health plan is around 92 to 93% MLR, which is we need to be kind of below that target to be at a sustainable point, which is roughly where we've operated at historically. And then you see in 2025, there was sort of this dramatic trend that continued to increase. Really in the second half of 2025, it accelerated. As we've looked at that further on the next slide, we can really narrow in on some of the specific populations within County Care where we're seeing those changes. So the ACA adult population, that first line there, had a 3 to 4% jump in their medical loss ratio, and then all of the HBI populations, which are all of the immigrant populations. So HBIC is immigrant children, HBIS is immigrant seniors, and HBIA is immigrant adults, which of course termed out of coverage in the second half of 2025. But you can see all three of those populations had very dramatic increases in their medical loss ratios from 86 to 116%, so almost a 20 percent jump, and that's really true across each of those immigrant populations that we're serving. So we suspect that a lot of what we're seeing is that these are populations that have more concern about losing coverage based on the federal policy changes that are going into effect in January 1st, 2027. And so they seem to be seeking out care now ahead of those potential coverage losses. So we think we're seeing a surge in that utilization for these populations, trying to take care of, their medical care now with concerns that they may lose coverage in the future. So I think it remains to be seen of whether this is just sort of pulling forward some of that medical care and that we'll see this smooth out over time, or whether this will be a sustained trend that we see.
I have a question. Now, what types of things are you talking about in terms of medical care? It's not routine exams, it's more procedures that we're seeing, things that you wouldn't typically see?
Yeah, so as we have looked into that deeper, it's where we're really seeing an increase in utilization is claims that cost between $1,000 to $10,000. So it's not sort of the routine primary care visit that's $100. It's really some of those more surgeries, elective procedures, smaller items that maybe individuals would have put off for some period of time that wasn't super acute at this point, but now they want to make sure they get it taken care of. And that seems to hold consistent across each of these populations that I mentioned, so the ACA population, HBIC, and HBIS.
Aaron, if I could, in follow-up to Director Harrington's point, do we believe that the increase relative to the cost ratio may also be driven by individuals seeking treatment later than they might have otherwise because of concerns either with coverage or ICE or factors such as that? I mean, there's quite a difference between you coming in and you have a grade 1 cancer versus a grade 4.
Yes, I think that is a underlying concern for us, particularly in the immigrant population. So, to sort of separate these to the ACA adult population, we've seen sort of utilization increases really across the board, including in PCP visits, but also in that $1,000 to $10,000 range that I mentioned. On the HBIC and HBIS populations, so the immigrant populations, we've really seen a dichotomy there. There's a big drop-off in utilization in the lower cost services, so the basic office visit services, which we anecdotally suspect is that fear of ICE enforcement, other things driving that. But then we're seeing that increase in the $1,000 to $10,000, and even in that $10,000 to $25,000 range. So, I think one of our long-term concerns there is that if we're not getting the preventive care in that population, what that's going to lead to down the road. So in terms of what actions we're taking to address that, we've really set out a strategy to be fairly aggressive on mitigating some of the financial challenges that we're seeing from these changes in utilization with really a two-pronged goal. One is to right-size the health plan in terms of our operations and our financial performance, but also to ensure as we head into 2027, when we know that these coverage changes are going to be in effect and that the health system on the provider side is going to be facing much more challenges in terms of a shifting payer mix, that we're in a good position to support the health system, or at least not be a continued negative trend on the overall health system's financials. So it's really important for us to right size this year and make sure that we're in a sustainable position going forward.
What do you mean by right size?
Bring our revenue and expenses into alignment. So on the next slide, we start showing some of the actions we've been taking. So as I mentioned, we've executed about $32 million in cost savings initiatives in this quarter. We had about $18 million we executed in the fourth quarter of last year. So we started taking actions as we saw some of those trends evolving. And then we have another $40 to $50 million of cost savings initiatives that we're looking to execute on in the second quarter of this year. And I'll talk a bit about what some of those items are to give the committee a sense of where we're targeting savings from right now. So on the next slide, this gives you a sense of some of the items that were implemented over the course of the tail end of 2025 into the first quarter of 2026. So these are things like looking at alternatives and drug therapies like biosimilars that have better cost savings opportunity but similar efficacy. We've reevaluated a number of our contracts and exited some contracts that we felt like were underperforming. We've relooked at all of our rewards that we have under our member benefit program and looked at which rewards we felt like were effective at having an impact in driving certain behaviors to drive quality scores and which ones were not, and made some changes there. And then, we've continued to especially look on all of our admin costs and wound down some of those items that, again, we either felt like weren't strong value or we had opportunities to renegotiate, et cetera.
Yeah, I just want to make an observation, and I'm assuming that you will verify this, that doesn't mean there's any difference in the quality of care that we give or what patients receive. That we're doing this and the quality of care remains high.
Yes, I definitely agree with that. I think as we go through these initiatives, I think especially what we have targeted to this point are things that we've been very thoughtful about in terms of what has minimal provider impact, minimal impact on the member. I will say as we look going forward, if the environment continues to be very negative, we'll face more challenging decisions on that front. Some of the changes that we would have to make to continue to drive savings are going to be more challenging in terms of what those impacts are going to be. But I think to this point, we've been able to take a lot of efficiencies out of the, through the program that have minimal impacts on members and providers. The next slide shows what some of those initiatives are that we've executed on in the first quarter. Some of those are changes that the state has built into their risk adjustment program to address some of the underlying concerns we've seen with things like our NICU cases. We made some additional reward changes. We've built in some reduction in our marketing expenses as we're looking to the next year. We've renegotiated a number of our value-based care agreements to, again, look at what's kind of most effective and what's been maybe not as effective and where there's opportunities there. And then we've continued to build additional reductions in either consultant use or other administrative contracts. And that'll be a theme that you see on this next slide for the second quarter as well. We have looked here at some benefits, value-add benefits we provide to our members, and we've realigned some of those. So our food care program is one of those examples where we've narrowed the targeted focus of that to really be individuals with certain diagnoses. So, for example, individuals that have diabetes, for example, or gestational diabetes, versus having maybe it broadly open to our entire population. So trying to target it to the populations that will see the most value from it. We've made a number of administrative contract renegotiations are in progress right now that we expect to drive about $14 million in total savings. And then we'll be renegotiating provider contracts and are in the process of doing that this quarter as well.
Before we go forward, I just want to shine a light on the fiscal resilience effort. We recognize it's not easy, and just want to say thank you for the thought and the effort that's gone into this.
Thank you. With that, I'm going to turn it over to Dr. Tanksley to talk a bit about our NCQA health plan timeline.
Good morning.
Good morning.
Good morning. So I am going to walk us through just a couple slides here about our NCQA, where we are, where we're going, and the strategy that we're using to march forward to our 4.5 stars. And so currently we're in this January to June area where, as Aaron mentioned, our CAP survey is currently still fielding, but will be closing soon. Our HEDIS reporting projects are being completed and for the most part are near completion. In early May, we'll actually confirm that we have all of those details. Those things are going into the portal, and then in June, we'll submit everything officially. Once things are submitted, then in early August, we'll actually get some projected ratings that we'll have an opportunity to look over and confirm, and then early September, we get our internal ratings, our final ratings, and then that is publicly released in the second half of September. And so we're marching along that way. We're doing really well. To Aaron's point, don't want to jinx it, but we are seeing some very positive changes from the year over year. So next slide just kind of tells a bit more about the methodology that we're using. So overall, just for the committee to be aware, the overall rating is a weighted average of the plan's HEDIS and CAPS measures. The rating is 0 to 5, and it's rounded to the nearest half point. So hence the reason that we say, 4 stars, 4.5, those types of things. The patient experience is captured through the CAPS survey. The rates for the clinical measures captured through the HEDIS. And then the overall NCQA plan accreditation accounts for an additional 0.5 bonus point. So as far as where we are and what we're doing, our measures do have different weights. And so we have focused our strategy on the triple weighted measures to ensure that we're able to move those strategically forward. And those measures are extremely important because they don't just talk about the process, they talk about the outcomes. And so, and hence the reason that they're weighted a bit differently. And so they show, to Director Harrington's question earlier, about the quality of what we're providing as well too. And so we're very focused on those, again, trending in the right direction, and looking forward to being able to have those final ratings for you guys. With that, if there are any questions about NCQA, I'm happy to take them. So I'll turn it over to Chrissy Torino for our transformation and growth. Continue.
Thank you so much. Thanks, Dr. Tanksley. Good morning, directors.
Good morning.
So I'll share some information about the changes to the Medicaid program as a result of HR 1. So as we have reported in the past and shared in the past, there are changes that are coming to the Medicaid program as a result of what is called the One Big Beautiful Bill Act, or HR 1. There has been some guidance that has come down from the Centers for Medicare and Medicaid Services that is required to be implemented by the states. And so those include mandatory work requirements, so work requirements for non-disabled Medicaid members that are between the ages of 19 and 64 without dependents, for those, and then also for some with dependents that are over the age of 14. There's also going to be more frequent redeterminations for the Affordable Care Act adult population, all of those beginning on January 1st. There will be some exceptions to those changes that are coming, and those many exceptions are on the right-hand side, though we know that there will still be many who will be impacted. On the next slide, we go a little bit more in depth on the changes that are happening for specific qualified immigrants. So in October of 2026, there are certain groups of immigrants that will no longer qualify for the Medicaid program. That includes refugees and asylum seekers, victims of domestic violence and trafficking. There are other, and the majority of individuals that currently qualify for the program that are undocumented, and children that are under the ages of 19, pregnant individuals, they will all still qualify. So there are still many groups that will qualify for the Medicaid program. And then I mentioned on the previous slide some of the changes that are coming related to the Affordable Care Act adults. They'll be required to demonstrate that those 80 hours of work, school, or volunteering. So we'll be working within our redetermination events and in partnership with Cook County Health, and in making sure that as many people keep their benefits as possible. On the next slide. So we wanted to share a little bit about our strategy at the county care level, and we'll talk in just a moment about some of the great work that's been happening and really been spearheaded by Cook County Health. But from a county care perspective, we are focusing our work in these three pillars. So through communications, making sure that we're communicating key messages to our Medicaid members. We already send out timely information through text messages, through postcards to our members when they're up for redetermination. That'll continue to be very critical as these changes come. We're working with Cook County Health in the development of all the communications, but Cook County Health also launched this last week, and we'll share a little bit more, a microsite and a toolkit really under the leadership of Alex Normington, who's here in the room with us. We also created an FAQ document, Commissioner Lowry, at your request during our last meeting, so we have that here for you today.
Good.
And then for outreach and partnerships, we're utilizing our redetermination events, as I mentioned. And then we have quite a few other committees that we convene that we'll share in just a moment. And we'll be working to get feedback and make sure that our messaging is as clear and as impactful as possible. And then we'll also be working to do data sharing in a compliant manner to ensure that those individuals that have to take some additional action, for those that are our contracted partners or providers, that they have the information at hand so they can support those members with redetermination as well. So if you go to the next slide. So we'll first talk about outreach and partnerships. So we have shared that we complete redetermination events out in the community, and on the next slide I'll share some data about how many events we've had and how many folks we've served. We believe that that will be a key way that we support people face to face. We also have a phone number that people can call and get support over the phone. We also have a community stakeholder committee that meets quarterly and is a group of community-based members, community-based organizations, and so we'll be utilizing future meetings to get feedback on our communications and really the ways that they would like to receive support. Our Enrollee Advisory Committee also meets quarterly, and we'll similarly utilize that forum to get members' feedback on the materials that we're putting forth. And then Cook County Health has really been the leader in convening the Medicaid impact work groups under the leadership of Dr. Makaitis, and ensuring that all the community is coming together with healthcare and family services to support these members. Yes.
Yeah, how large is the Enrollee Advisory Committee, and is it reflective of the general population we serve?
Yeah, so the Enrollee Advisory Committee is made up of county care members, so we invite county care members to come out. We generally have a specific topic, so in the past we've done specific topics around maternal and child health care in our Brighter Beginnings program. So we'll have one Enrollee Advisory Committee that will likely be focused with Affordable Care Act adults to see what kinds of messages resonate with them. So we're able to do a little bit of targeting in who we invite to that committee.
So we have more than one, or?
It's one committee that meets quarterly, but it's different members that come every time.
And how many people are we talking about?
It's usually about, I would say like the average is about 20 people come out.
And it's representative of our population overall?
It is, though sometimes we have targeted topics, and those topics sometimes kind of, we'll focus on for our Brighter Beginnings program, get feedback from kind of the maternal and child health program, population, so folks of a reproductive age. So we try to kind of have focused populations based on the topic as well.
Thank you.
Yes. All right. So on the next slide, so this is the graphic that we've shared quarter over quarter on our redetermination events. So this shows data from April 2025 to March 2026, where we held over 230 events, and we serve not just county care members, but any member of the community that comes out to get support. So overall, there were 11,800 members or so that came out, and of those, just over 6,800 were county care members. And the attendance has been pretty usual, of about 50 members or so have come out on average per day. So we also, I mentioned the Medicaid impact work groups that are being convened by Cook County Health. This has been a group of over 60 organizations. So far there have been 2 meetings, but there are several subgroups. Our strategy is definitely mirrors and is in partnership with those 3 subgroups, including coalition building, communicate and educate, which has really been focused on communications improvement, and then innovate and create has been focused on systems and ensuring that we get the right information to the right helping organizations in a compliant manner. And on the next slide, we just wanted to share some of the assets. Again, all of the credit goes to our wonderful communications team in the development of this toolkit. This has been developed to be unbranded and available to the community so that so that trusted messengers within the community can put their own branding and information and get this information out. The most important thing is that everybody is aware. The messages right now are that changes are coming to Medicaid and for folks to update their information with the state. On the next slide, you'll see just a view of our microsite, which has our redetermination events prominently located on the front page. This will be a landing page to provide timely, useful information on an ongoing basis to members of the community, especially as these changes come. And last but not least, data sharing. So one component really is going to be around making sure that we provide information to the state as much as we're able around those that might be qualified for exemption. So there are some folks that will not have to participate in work requirements and won't even have to show that they are working 80 hours or volunteering, et cetera. So we want to be able to show as many of those members as possible to the state to be able to potentially qualify for the medically frail designation. And then on the data sharing to partners, this will be ensuring that for all of the places where we're currently showing information about who is an Affordable Care Act adult, our member portal, provider portal, that they have the information to know whether they fall into the category that's going to have to take action. More frequent redeterminations, and then also whether or not they're going to have to participate in work requirements. And then the state has just reached out to the managed care organizations, and we will be partnering, in addition to in the Medicaid Impact Work Group, in hand in glove with the state in implementing all of these changes. All right, so I think that's my last slide on HR1. I know that was a lot of information. Any questions about that before I shift topics? Okay, next up is just an update on the Health Choice Illinois RFP. I unfortunately do not have much of an update, which is that we have not yet heard the notices of awards. That being said, we expect that the rest of this timeline will still proceed, so an operational start date of January 1, 2027, with readiness review and all the plans having to come into readiness for the new contract requirements by January 1st. And then we do also expect that they will execute contracts this summer. So those are some of the upcoming milestones, and the county care team has already done a crosswalk between the old and the new contract, and are taking steps that are required just to make sure that we don't get behind. So if you go to the next slide. Oh, sure. Yeah.
Impact your ability though to meet that January 1 if you're needing to enter into new contracts, or you just assuming that?
Of course, we're waiting for the response back from the state. That being said, there are quite a few new changes in the contract, and so just to ensure that we don't get behind, there are also quite a few requirements that are due within 10 days of contract execution. That would be July 1st. So we're preparing all of those materials as if, so we're still waiting to hear back from the state.
I have a follow-up question. So we were expecting a response on or around March 1st, I think, and we're now heading to May 1st. And let's just say the end of the session occurs, the end of May. Will this process continue into the fall, or is this, do we have to do a redo? What's the process as we go forward?
Yeah, so our contract, our current Health Choice Illinois contract goes through the end of this year. We do anticipate that the state will transition to their new contract cycle on January 1st of 2027. So we anticipate and hope to receive notices from the state in the next few months. I think as long as we don't get past kind of the summer for notification, we would still be on track.
Great.
There are quite a few requirements and things that the state, works with the plans in preparing, such as a formal readiness review. So all of those steps would need to occur prior to the new contract start date.
Thanks, Chris.
Thanks. Okay, so now I'll shift a little bit to our workforce. We had a survey, the employee engagement survey that occurred in 2024 and was across Cook County Health. So we got those results back, refined those, and looked at these 4 key areas, which were really clearly defining job responsibilities, promotions and career development, departmental collaboration and removing silos, and recognition. So this is what we heard from our team that they wanted us to make some improvements on. And if you go to the next slide, we might have lost a slide in there, apologies.
I went the
progressed
wrong
this one.
way.
Sorry. There we go. Okay, great, thank you so much. So on the next, so this slide just shares a little bit of what our action plan was. So we learned from some teams that there was a little bit of inconsistency on when one-on-ones were happening. We increased the frequency of one-on-ones between supervisors and their team members, and also provided some training, thanks to the Cook County Health HR team, on how to make those one-on-ones work very well. We also hosted our first all-staff departmental fair, where they actually created poster boards and shared what they do, and ways for them to collaborate with one another. We continuously shared updated org charts so folks knew about positions that were coming vacant, and then also focused on professional development action planning, and hosted a kudos ceremony. All the pictures there are of Erin passing out the kudos awards, and team members were able to nominate other team members. We had over 200 folks come out to the kudos ceremony, and it was really well received. If you go to the next slide. So we, as County Care as a department, just hosted a pulse survey where we were able to send out a little bit of a smaller group of questions, but still get back information against our baseline for that engagement indicator. That was kind of our key objective and key result that we were looking at. We fielded the survey from January through February. We had 256 respondents, which was a 65% response rate, which was a little bit lower, but we fielded it for just a very small period of time to get some team member feedback. We saw an increase from 4.18 in an engagement indicator in 2024 to 4.21. So that was what we thought is a great improvement. We were also showing 0.2 over the national average, and that's across all health systems that are surveyed through Press Ganey, who's our surveyor. And if you go to the next slide. So these are some of the things that we heard from our team members, that they are really proud to work for County Care and Cook County Health, that they'd continue to work for this organization 3 years from now, and if they were offered another position, they would continue to stay with us, that overall they're satisfied employees. So we were really happy to see those results. A couple of quotes there on the right. One person said, "I love this organization. I plan to stay here until I retire." We also split up all of those comments and share them out with each director so that they can hear back directly from their teams, and it's all anonymized. On the next slide. We also had some opportunities for improvement. So 2 of the areas that we'll be focusing on over this next year are recognition, and then also continuing to share where there are opportunities within the organization, and then also just trying to make sure that people on our team are given different resources for professional development opportunities externally, and then also internally. There's lots of different programs internally as well. And so on the next slide, we also have a very active staff engagement committee that hosts all of these events. And so they are hosting midday mingles and have continued to have a program throughout the year. They host professional headshots, focus groups with Erin, where Erin gets direct feedback and then implements those within our team. We have quarterly newsletters. We're going to have a department fair again, and our holiday and kudos ceremony again. And then we have ongoing volunteer opportunities. So, for example, we have an upcoming baby shower, and we share that as an opportunity for team members to come out and support those events. And we also have monthly lunch and learns based on topics that our team members share would be helpful to them. Have a lot of external organizations come and share resources that are available as well. All right. So I think I have one more slide left. So our town hall is next week on the 22nd. And then, as I mentioned, we have an action plan that we are putting together. We'll bring it to the team for them to provide some additional feedback. And then there's also going to be an all Cook County Health employee engagement survey that'll be conducted this summer. So we'll be able to get some updated results and see how these changes are impacting the team. And I believe that's my last slide.
Dr. Makaitis, anything you'd like to add?
I just want to take a minute to commend the team on the incredible work that they're doing. I know a lot of, especially financial headwinds, right, given all the challenges, and I think they've come with a very thoughtful and nuanced approach around how to respond, and I think there's a course to stay fiscally viable within the plan, so I really commend you guys for that. And I just wanted to flag, a 4-star achievement is no small thing. I think that's the top 20% in the country as health plans go for Medicaid managed care plans, and striving for 4.5. There are only 14 plans in the country right now that have a 4.5-star rating. So to make that, I don't think there's ever been a 5-star, right? Yeah.
So here. Thank you, Doctor.
Thank you.
Thank you. Any questions, comments by any of the directors?
Keep up the good work.
There you go. Okay, so thank you to the entire team for not only your report today, but all your good work. We really appreciate you. I will be bugging you to make sure that I can get you guys out to the community because you make me look pretty good. So thank you. I really appreciate you. With that, our next meeting will be of the Managed Care Committee will be held on Friday, July 10th, 2026 at 10 a.m. And having no further business before this committee, Director Masuda Barnett now moves adjournment. Is there a second? Seconded. All those in favor say aye. All opposed? We're adjourned. Have a wonderful weekend, everybody. Thank you.
You should have opposed the motion.